I'm really delighted to join this Ideal Care conference. So, first of all, let me share my POEM procedure. And we started in 2010 at Hong Kong. So right now we have treated more than 400 cases. And I think probably I don't need to introduce you too much about the POEM. I think a lot of people knows about the POEM, but this is really the first breakthrough in terms of the first phase endoscopy, where we developed a submucosal tunnel and through the mucosal incision all the way to the gastric cardia, extending across the GE junction. And afterwards, we will start on the myectomy in the proximal part of the esophagus all the way to extend to cardia. So this myectomy should be performed either anterior or posterior approach. So I generally do anterior, but I think most people now do posterior. And I selectively only do inner circular muscle fiber myectomy. But there are also faculties who attribute this to a full thickness at the pathological site. But I think that's from all the studies, there's probably no definite difference in terms of the clinical outcome. And most importantly is that after the myectomy, we have achieved a good hemostasis and a secure closure of the mucosal entrance, which is not overlapping with the myectomy site. So in no single level of the esophagus did we perform a full thickness incision. So that makes this first phase endoscopy safe and with a high effectiveness in the treating patient with achalasia. So from our results, our overall success in clinical symptom relief is 95%. We have around 5% patient with recurrence, while for the GERD symptom, around 22% of patients have GERD symptoms after POEM procedure. And with that lead by the Amsterdam group, we actually joined this randomized control trial comparing POEM against pneumatic dilatation for treatment of achalasia. So I think this diagram nicely sums up the results of this randomized trial. 67 received POEM, 66 received pneumatic dilatation. The treatment success was 92% in the POEM procedure and 54% for the pneumatic dilatation, which makes a significantly difference between the two treatment of 38%. So this is, I think, the important landmark randomized trial that established the success of the POEM compared with pneumatic dilatation for treatment of achalasia. But as I mentioned previously, that there are around a significant number of patients who had a GERD. So this is a invention by Professor Haruhiro Inoue of managing GERD from the POEM procedure, where he actually performed a fundoplication through this submucosal tunnel to pull the anterior part of the stomach and attach it to the myectomy site through the anterior approach. So this is his initial video that used a clip and the loop technique. And I think now he is also using the suturing technique for fixation of the fundoplication to the anterior side of the esophagus. So by using this clip and loop and applying the clip to the anterior surface of the stomach and also the myectomy entrance, then after pulling of the tightening of the loop, the gastric fundus will then be pulled back to the myectomy site, covering the myectomy site and tightening the GE junction. So the further results of the efficacy will have to be awaited for longer term results, but this is certainly an innovative way to prevent GERD after POEM. And by now, with 12 years of development since the first case of a POEM procedure, the first phase is really extending. You can see a family of endoscopic procedures being developed under the umbrella of a POEM for treatment of different GI diseases. For example, for achalasia, we have the POEM. For the submucosal tumor, we have the STIR or the POET. For the gastroparesis, we have the G POEM. For Sancus diverticulum, as demonstrated before, is a SET POEM. For esophageal diverticulum, plus or minus association with achalasia. We can also treat it by DPOEM. For esophageal stricture, we have the poetry, and also for Hirschsprung disease, as pioneered by Dr. Amol, Bapaye is PREM. And I think the difference between minimal invasive surgery against a first phase endoscopy is that we actually approach the same disease with the endoluminal approach. So we expect the patient will have even less or no pain with an earlier recovery. So even with the minimal invasive surgery, we still induce pain over the few keyholes. So without incision, I think that is a big advantage. And definitely there will be a certain advantage if we are going through the thoracic cavity for treatment of a submucosal tumor or a myotomy. So for treatment of submucosal tumor in the GI tract, nowadays we are using the submucosal tunnel endoscopic resection or the peroral endoscopic tumor resection. So in different approach, in different location, we have different technique. For example, if the submucosal tumor is located at the gastric cardia, we are usually approach through the distal part of the esophagus. If the tumor is located at the antrum, then we actually go through the antrum and with the incision proximal to the tumor. If it is a esophagus, then the tunnel is probably more direct. So the technique of this POET or the stir is important because if we are developing a really long submucosal tunnel proximal to the tumor, we might actually miss this kind of tumor, especially in the stomach. So usually I leave a 2 centimeter of tunnel development and then dissect the tunnel between the tumor and the mucosa, and finally to dissect the tumor from the base. And the development of POEM and the first phase endoscopy is tremendous because we are using the ordinary instrument that we actually use for ESD procedure. So this is a video to demonstrate the POET or the stir procedure. So as you can see in the esophagus with a submucosal tumor, we open up a around 2 to 3 centimeter of mucosal incision, and then continue the submucosal tunnel development just around 2 centimeter proximal to the tumor. And then we identify the tumor border and then dissect around. So sometimes bleeding can occur because the tumor is supplied by the vessel. So we have to be carefully achieve a good hemostasis. And also we definitely need a CO2 for insufflation because within the first phase, too much insufflation, the gas is actually going to escape inside the mediastinum to either cause a surgical emphysema or a pneumoperitoneum. So, you can see now we identify the tumor, we dissect the tunnel surrounding the tumor, and also make a space distal to the tumor, and then continue this dissection. So one of the biggest limitations for this procedure is that we are working within the tunnel. So the space for manipulation and dissection is really, really limited. So sometimes our dissection knife is really close to the tumor. So in the esophagus, most of these tumors are leiomyoma, so we are not too worried about breaching the tumor capsule. So this is the final part. We are actually cutting into the muscularis propria layer, and then we are finishing the procedure and come with a combination of the dual knife and also the IT nano knife. We can complete this dissection and then retrieve the tumor perorally. So now we have performed almost 100 cases, and this is a recent report at the surgical endoscopy in 2019. The mean size of the submucosal tumor we resected were 20 millimeter. Most of these tumors located at the gastric cardia, the antrum, and also in the esophagus. So some of these tumors required a conversion. For example, in the esophagus, the tumor is too large that we convert to laparoscopic tumor retrieval or a full thickness resection in the stomach. So these are a prospective core study, and mostly from China, about the stir procedure. So the mean size of the tumor is very similar, around 20 mm to 25 mm. Operative time is also similar, around 60, 70 minutes. And overall resection rate is quite okay, ranging from 80 to 100%. Most of these tumors are either GIST tumor or leiomyoma. And you know that, as I mentioned before, we have a lot of different procedure being developed since the performance of the POEM procedure. So for the Sancus diverticulum, as mentioned before, is outpoaching at the Achilles eminence, and the treatment in the past was endoscopic septotomy, ranging from the endoscopic performance to a open procedure. So nowadays we can actually develop a tunnel and that manage this procedure. So this is one of my procedure. So using the latest Olympus system, actually it is the EX1 system. So with enhanced texture. So the distal attachment were actually a dimension from Professor Inoue is the space adjuster. So very soft cap. So we first incise and inject with the normal saline and illegal carmine, and we cut at the middle part of the ridge, the septum, and afterwards we would develop a tunnel from both sides of the septum. And so the objective of this procedure is to cut away and to relieve the septum so that even the food cannot be accumulated within the diverticulum. So connecting back the diverticulum to the esophageal lumen. So in this video, the right side, lower side is the esophageal lumen, and the left side is the diverticulum space. So right now we are developing the tunnel over both sides of the ridge. And afterwards, we will start the myotomy or the septotomy that cuts between the ridge. And you can see that now we are using the triangle tip knife with a coagulation mode. It's a spray coagulation mode. So even within a limited space, we can actually achieve hemostasis and cutting with the spray coagulation. So now we are almost close to the distal part of the septum. I think this one of the beauty of this technique is that we are pretty certain about the distal part of the septum because we have no worry about full cuts in the lumen, so that we have a high risk of leakage. So now this is the diverticulum, and we have already completed all the septum resection. And then afterwards, we just close the mucosa with the clips. So similar to the POEM procedure. And afterwards, I think this is very secure. Actually, the patient can tolerate the diet on the second day and leave the hospital. So this is one of the largest cohorts published in GIE 2020, 75 patients from 10 centers. Mean operative time is 50 minutes. Hospital stay is 2 days. And significant improvement in the dysphagia score after the procedure. And certainly this procedure can be applied for treatment of a esophageal diverticulum, as demonstrated in this video. So very similar technique, development of a tunnel, and then expose the septum. And then after development of the tunnel and the exposure of the septum between the diverticulum and the mucosa, then we cut over the septum to relieve it so that the diverticulum will not be able to accumulate any food residue within. So very similar procedure, cut all the way to the distal end of the septum. So similar principle, and this is one of the report in the endoscopy with 11 patients with esophageal diverticulum, 7 Sancus, 1 mid-esophagus, 3 epiphrenic, and clinical success 100%, and also significant improvement in the dysphagia score. So I think now the technique also extends to treatment of different kinds of diseases. I think this is one of the very innovative way, recently published in GIE, of managing esophageal stricture after head and neck cancer with chemoradiation therapy. We probably all of us have encountered very difficult to manage stricture. And for this kind of procedure, we can first develop a tunnel from the proximal esophageal side, at the same time doing a pack, and then the retrograde develop a tunnel from the distal esophageal side as well. And then the two ends of the endoscopy can actually be meet, and then subsequently a stent was inserted afterwards performed serial dilatation. And in 4 patients reported by Professor Dragunov, there is a significant improvement in terms of this dysphagia and 100% technical success. For gastroparesis, GEPOM is being developed, and a similar principle, probably the submucosal tunnel again can be developed at around 2 centimeters proximal to the pylorus, and then after the mucosal incision, then develop the tunnel all the way to the pylorus, and the pyloric ring is actually not very long, so you can expose the pylorus quite well, and then afterwards to cut the myectomy using the TT knife. So basically, this is a not so difficult procedure, but the clinical effect was quite significant, as demonstrated by the recent clinical reports. This is one of the systematic review recently published, and in the EIO 2019. Technical success was actually 100% for GEPOM, and the clinical success was 82%. And in gastric emptying scintigraphy, it demonstrated a significant reduction compared to before the GEPOM for gastric emptying. And most of the adverse events is actually pneumoperitoneum, and there may be some bleeding, abscess or stricture, but no mortality. So as I mentioned, the SIR or the POET procedure is ideal for submucosal tumor management. But however, sometimes when I'm dissecting this tumor, especially in the stomach, I actually worry about breaching the tumor capsule for GIST tumor. So for management of a GIST tumor, I think the submucosal tunneling technique have some limitation and worrying about tumor recurrence. So we have developed the technique of endoscopic full thickness resection for managing of this gastric GIST tumor. So this is a video to demonstrate the gastric GIST located at the proximal body of the stomach. And after a submucosal injection, we actually open up half of the mucosal incision and not the whole, and then exposing the tumor at the submucosal space. And this kind of GIST tumor always arises from either side of the muscularis propria. So we are expecting the development of a full thickness incision. So, very important, we are caring about the tumor capsule, so we have to leave a good margin. So definitely we need to cut into the muscularis propria to preserve a good tumor margin. So during this procedure, I need to achieve a good retraction. So one of the methods that I am doing is to apply a detachable clip with a suture that passes orally, and then after retraction of the suture or the string from the outside, I can actually retrieve the tumor to the inside of the stomach. And I think that within the GI lumen, the territory will be enabling the flexible endoscopy for dissection. So, and then the further dissect with the use of another clip and the suture retraction. And then we have to look at the outside of the serosa. Then now we know where is the location of the tumor border and the margin. And then we continue the dissection using the jewel knife to define the tumor margin, and then cutting that with the IT knife. And this is the final part of the resection. As you can see here, cutting into some of the muscularis. And then finally, I would first retrieve the tumor, worrying about that it drop into the peritoneal cavity. And then finally to close the defect by an Apollo overstitch. So I would generally use overstitch if the defect is 2 centimeters in size. So usually in the figure of 8 suturing, after suturing, we tighten the casing. Yeah. And this is the final part of the tightening of the suture. And the 2 sutures were applied. And then afterwards, this is the effect of the closure. So pretty much a secure closure after the EFTR. So you can also use other methods. For example, we're also using the creep and the loop technique. It is easier to use, and some of the location where the Apollo overstitch cannot be reached, like at the fundus, then this method is important. But generally speaking, we are using the overstitch for most of the case, especially we have now the single channel overstitch as well. So talking about the next development, I think from the first phase to the second phase, now we are back to the first phase, because as Wendy mentioned about the robotics, I think the future development of endoscopy also rely on development of a good therapeutic platform. And this is a idea and the technology developed by Professor Lawrence Ho from National University Singapore. Lawrence is here, and also Professor Louis Fee, who is our chief engineer from Nanyang Technological University. So I'm also the clinical partner, and we actually developed this master and slave transluminal endoscopic robot. And we conducted the first cohort study, 2 patients from Hong Kong, 3 patients from AIG India with Professor Nagi Reddy. We used this prototype robotic system for gastric ESD, and they are generally very successful, and also demonstrating the efficacy of the mucosal retraction with submucosal dissection using the robotic arm. But that is really just a prototype. So the second generation master system was brought forward by a startup company called the EndoMaster, and this is a totally redesigned platform with the robotic arm. And we have, after some preclinical trial, we have actually conducted the clinical trial in Hong Kong last year during the COVID pandemic. So I just want to show you one of the video to demonstrate this system. So this is a lesion located at 90 centimeters from the anal verge in the proximal transverse colon. The system have a 2 robotic arm, and so before the function of the robotic arm, we need some jiggling action, and then this system was brought into the colon by a independent endoscopic platform. We are using CO2 for insufflation. The video was played at 4 times speed. So the whole procedure is around 25 minutes. So this is the tumor. And after some mucosal injection with the oral gel, we first start the mucosal incision with the right robotic arm. So after an adequate mucosal incision, then our left robotic arm will be grasping the mucosa, and then subsequently lifting the mucosa for dissection. And then we continue this mucosal incision, and using this 2 robotic arm. So the lesion is generally put at the 6 to 9 o'clock position for the best ergonomics for the robotics platform to be functional. And then we started the mucosal incision from the near side. We don't actually complete the mucosal incision, same as what we are doing for the colonic ESD. And for hemostasis, we will use water flushing, and also use a coagulation mode of the right robotic arm. So interestingly, when you are doing the retraction, one of the way is to lift the mucosa, but the other way to manage the retraction is in fact to use the robotic arm to compress on the mucosal fold, like in here. So when I'm compressing over the colonic fold, I expose the submucosa again. So in this location, especially at the proximal transverse near the hepatic fracture, compression of that fracture helps to expose the submucosa. So there are multiple ways of retraction. I think that's the beauty of this system. And we are doing this submucosal dissection. So basically, we also need to pay attention to the mucosal margin, so not to cut into the tumor. So this is the final part of this robotic procedure. And after the completion of the robotic procedure, the specimen can actually be retrieved by this system. So now I think Lawrence and Louis and his team are developing a suturing method for endoluminal robotics. So I think if we have this system, there are a lot of other clinical applications like management of GI emergencies, morbid obesity, doing endoscopic sleeve gastroplasty, and full fingers resection with this suturing device. And I think there are also new devices coming up and passing try passing the GI lumen from the first base to the first base. So like the performance of a GI anastomosis using this GI windows. And I think the future development of the first base is also very interesting. This is one of the concept of a first base full thickness resection, where this is a report by Professor Goto from Japan. So first development of a ESD tumor to surrounded the submucosal tumor to the submucosal layer, and then afterwards closing the mucosa with the suturing, and then develop a tunnel all the way to reach this tumor like that, and then put the endoscope back into the submucosal tunnel and dissect completely all this tumor. So even if there is a full thickness resection within this space, the mucosa is intact because he has already sutured it. So that makes a interesting way of totally inversion of a full thickness resection using the first base. So I believe that the submucosal space or the first base endoscopy open a new horizon, and there's an unlimited development of procedure since we discovered the first base, and safety and efficacy of this procedure should be confirmed with well-designed clinical trials. While the future of first base endoscopy probably is to allow us to access to adjacent organ for diagnosis and therapy, or even performing advanced intervention in the first base by a submucosal tunnel, like implantation or innovative medical devices, molecular imaging for diagnosis, or even cellular therapy like stem cell therapy or molecular therapy for treatment of GI diseases. So finally, I think thank you very much for the invitation from Professor Wendy Deer, and I believe that we are only limited by what we can imagine. Thank you so much
for this invitation, and congratulations, Philip, for once again a phenomenal talk. It was fantastic, excellent talk, and I think you covered everything. Thank you for acknowledging our tiny contribution towards third space in terms of the PRAME procedure. Thank you very much. Now, I think you've summed up the past, present, and future of third space in a fantastic manner. So there's very little that I would like to comment upon except for congratulating you. But few thoughts that came to my mind, and what I wanted to, I don't have any slides. I'm not going to give any slides. But what I'm going to say is that there are certain areas that we need to look at when we are doing third space endoscopy, and where the future is, and how we are going to take it forward. One thing is that obviously we need to consolidate on the gains that we've made in the last decade regarding the procedures that have been performed. Now, for example, POEM and STIR are reasonably established. GPOEM is getting acceptance gradually, but there's still a lot of the other procedures. There still needs to be a lot of data, and so that we can get these procedures more into mainstream. That is probably one of the most important things in the next few years that we need to look at doing, because we need to position these procedures now in terms of the currently available standards like laparoscopic surgery or whatever resection modalities. So these things are there. The second thing is obviously instrumentation and equipment, and the developments go hand in hand. So you have very clearly demonstrated the role of robotics as it is coming up. Also the newer development of instruments which will make things easier. The imaging, now the newer imaging with the RDI and TXI technology, which is making the resection safer. We can treat bleeding spots, we can control bleeding much more effectively. So these things are going to make a lot of change. Another area would be energy sources, because I think energy sources are also evolving, and presently we are all limited to monopolar diathermy, but I think bipolar and microwave and probably even harmonic is in times to come will make things much more easier. And with that, probably we could also use third space as an access route to get into the peritoneal cavity, and also perform some surgical procedures on solid organs. We don't know as yet, but then time will tell. One important aspect that I would like to touch upon is that is about training, because I think training in third space is a challenge currently. I think many of all of us over here sitting here are involved in some way or the other. But I think the divide, or not exactly a divide, the difference is that most of the GI endoscopy today, which is being practiced worldwide, is by physicians and not by surgeons. And it's not a question of surgeons or physicians, but I think we need an aggressive physician or a conservative surgeon to take third space endoscopy forward, whoever, and as probably in combination, or in, as a team. But what is important is probably opportunities for training. That is what is going to become more and more challenging. So models, porcine models or live models, all these things are going to probably need a lot of thought, and we need to also standardize the training program. Also, the credentialing and accreditation is also going to be an issue. And as I said, one of the important things is the emerging data, and we need more and more randomized studies comparing these procedures to the current state of the art or the standard procedures. And the last thing which I would like to say is third space endoscopy has really revolutionized and interventional endoscopy in a many big way. And probably what it requires from each one of us is more of a mindset change. I think changing the mindset is going to go a long way, and that mindset has to be in terms of the intervention, the adverse effects, the indication for the procedure, what the patient's choices are as compared to the third space endoscopy procedure that we are offering to the patient, whether it is pharmacotherapy or surgery, conventional surgery. So all these things are actually the next decade. So POEM has celebrated its 10th anniversary last year, and as it gets into its adolescence, we've started seeing that reflux has started emerging as a problem. So now we need to address that. So all these things are going to evolve in the next decade, and probably we can say that in the next 10 to 15 years, the third space endoscopy would mature into a separate subspecialty. So I think that is the way I would like to summarize this. If you have anything else to add, I think we can surely do that.